So my name is Dr. Matt Campbell with AcroPsych, and today we're going to talk about the DSM.
Okay.
So the DSM, or Diagnostics and Statistical Manual of Mental Disorders, which is quite a mouthful in of itself, is different than how a lot of diagnoses happen in the rest of medicine. Some people refer to as the psychiatric Bible.
Oh.
It's the whole list, an entire book that gives us all of the diagnoses that we work with in psychiatry.
Okay.
Which is somewhat unique to psychiatry in the field of medicine.
Okay.
So as most people who've gone to a doctor have realized, you usually get a diagnosis based on a disease.
Mm-hmm.
And disease is different than disorder or syndrome, which is what we work with in psychiatry.
In what way?
Disease tends to be focused on having a causal agent connected to all the symptoms that someone experiences. So you have to know what's causing the problem for it to be a disease.
Okay.
So in psychiatry, we're more at the stage of observing, these are all of the symptoms, these are the ways in which someone feels, this is the way in which they describe themselves, the way in which they're behaving.
Okay.
And it's a constellation of symptoms.
Okay.
Or experiences, which puts it in a syndrome, or in psychiatry refer to disorder, because it's a deviation from normal.
Okay.
So it's different than disease, and why a good example of how that can change over time is Huntington's disease.
Okay.
And so Huntington's disease is involuntary movements. Sometimes people talk about Huntington's chorea, and this is this very specific type of abnormal movement people have with Huntington's disease.
Okay.
And so in the 1800s, a doctor in Long Island actually was seeing a lot of people. It's a very rare disease, but he was seeing people, multiple people, with this kind of specific movement, and he was trying to observe it.
Mm-hmm.
And it took from 1800 of different doctors, providers, and people specifying all of these different kind of abnormal movements, all of these different kinds of things they would observe or different kinds of things they would subjectively feel. And over a course of 100 plus years, in 1993, they finally connected that to a specific genetic disorder. And so they now, if you say you have Huntington's disease, you're actually doing a genetic test, you're finding that genetic problem, that trinucleotide repeat, and you're saying if they have that with these specific movements, that means they have Huntington's disease. And as you can see, it took a very long time of refining, this is what we're seeing, until finally technology in progress made it to where we could connect it to a disease. And so these abnormal movements, though, as you observe them, you can say that that's distinct from other abnormal movements that we see with Parkinson's. The tremor that you see in Parkinson's is different than the kind of movement you would see in Huntington's.
Okay.
And so as doctors and people are going over the course of time, you're refining, these seem a little bit different than these other ones. And
this type of disorder is different than this type of disorder.
Right, because the progress of, say someone shows up with a tremor, the people that it shows up in, the age in which they show up in, who it transmits to the next generation is different. How they progress over time once they demonstrate these is different. And so you start characterizing and specifying these in different buckets because they seem to be behaving differently.
So you're able to say these are different disorders.
Exactly, until finally you have more of a specific disease. So Parkinson's disease, they've been able to also connect that to specific problems in the brain, that they're able to say, okay, when this happens, this leads to Parkinson's. In psychiatry, we don't have that level of specificity in regards to, these are all of the causal, specific causes to this specific disorder. Why is that? I mean, part of that is because I believe that just the brain is so much more complex than a lot of different organs that we have in our body. And the actual discovery and the scientific research in the brain is a lot newer. So if you look at the heart or the kidneys, so much progress has been made to where we really understand a lot about the heart and cardiac disease and what goes wrong and what goes right. But the brain, especially as it relates to behavior and emotional, processing, emotional connections, it's so much harder to understand because it's such a complicated organ. And then on top of that, you add behavior and how people interact. It's so much variance. You have cultural differences. So even if you just think of like a scientific, a lab that you can find, it's hard to say, how do we define something based off of abnormal behavior? Because different groups of people interact differently.
So you're saying the behavior of the person is what psychiatry is based on, as opposed to the behavior of a heart or the behavior of a kidney.
Yeah, which
Right.
is just such a more difficult question
Right.
because you don't know the behavior and what its function. How is it supposed to function in this specific context?
Ooh.
What are all the variables contributing to this
Right.
context? It gets very complicated. And so I think we have to understand psychiatry that we're really looking at a very complicated problem.
Okay.
And we still are making progress towards understanding all of the specificities of what is exactly different, what categories is more specific.
Not to take us on a tangent, but that probably relates to like very interesting cultural disorders, quote unquote, or cultural phenomenons that happen in maybe like a very specific region of the world, and maybe that has to do with something culturally that they value and how they behave.
Yeah, they're. I don't remember if they're in the DSM-5, but I do remember when I was in med school, you would get questions on kind of random, very culturally specific phenomena that happened in different parts of the world.
And so the disorder of psychiatry, because it has to do with so much variance in behavior, creates like a variance of creates more difficulty in narrowing down the root cause of something. So
Yeah.
it's a disorder instead of a disease at this point. Interesting.
And I think that's important to know is that, well, then why do we even bother with it?
Okay.
Which I think many people will question or even have some sort of critiques of the DSM because of this. And I think it's important to realize is, say we didn't have this DSM and we didn't have any sort of categorization. Instead, you would still have all these problems people are suffering with, but you would have individualized ideas on what it is. So you get on TikTok and YouTube, and you'd have just a million different people's opinions of what the disorder is, which we do get some of that to a degree, but at least we have.
They're still out there.
There's still that, but we at least have some agreements of this is what is the typical diagnostics that we're going to look at.
Within the medical psychiatric community.
Exactly, which helps then different. So if you go see a medical professional or a psychologist or a social worker, all of them are working within the same diagnosis. So we can bring in our own understanding and we can bring nuance to it, but we also are at least going to start with this basics of these are the basics we understand. And that allows us to communicate between different professionals.
Right.
It also allows us to communicate with patients because if you can imagine, if you are a patient and you're given a disorder, like a diagnosis of, we believe you have alcohol use disorder, if every single provider gave their own name to that, that would be very confusing when you were talking to any of your friends or anyone else of being like, well, what is that?
Right.
My doctor calls it this, my doctor. So it gives a uniformity for us to discuss it. And I think just as important to that, if not more important, it gives us an ability to do studies and research. And so we can say, since we've done a lot of research, is if someone has alcohol use disorder and they fit into that group, we can then say, okay, if we try this intervention, who responds, who doesn't? And we have a lot of then ability to match a disorder or a group of people, what they come in for, and actually connect them to an evidence-based treatment.
So you still might not have the science to say this is exactly what's causing this disorder, but you do know there's a correlation between like a medication or therapy that aids in sort of toning down the disorder or even resolving it.
I think a good way to think about it is because we have an ability to do research studies, we're able to say, okay, this is the criteria. So anyone who fits within this criteria, we're going to try this intervention. And so now someone comes into my office and I can look at the studies and be like, okay, people that fit this criteria,
this age, this weight, this ethnicity group, maybe this kind of home environment.
Yeah, so exactly. And a lot of them, they will list out all of these potential confounders and these different kind of variations. And that's part of the reason why it's so important to read through and understand what the evidence base is. By being able to see someone and put them in the right diagnosis, I'm able to match them to the evidence base that's out there and say they're likely to improve with this medication.
Okay.
The outcomes can vary, but we at least know these are the type of treatments that are going to help this person sitting in front of me.
Okay. So not to stray too far from the DSM, but the DSM is a list of the symptomatic criteria most commonly associated with the disorders?
Well, it's specifically a criteria. So it is all of those criteria, but it's going to make like a cutoff point.
Okay.
So it's going to say, in order to have this disorder, you have to demonstrate these specific symptoms for this amount of time.
Okay.
And for some of them, you even have to layer on multiple criteria or exclude certain things.
And that is the consensus agreed upon definition of a disorder at this moment in the psychiatric community.
Yeah, exactly. And it is important to know that putting these together, it's a huge amount of psychiatrists, psychologists, social workers, scientists that are coming together to review the evidence base. And so they will be looking at how things pass along genetically. What kind of neuroimaging and brain studies have they looked at with these different groupings? What kind of lab work? What kind of abnormalities have we seen? So this isn't to say that there's no scientific basis on any of these. They actually do look at that, and they just don't have it so clearly lineated as one cause to effect. This could be some degree of that multifactorial contribution to what we're seeing.
Because you were saying earlier, like pneumonia, you take an x-ray, you see the blob in the cell is clearly causing pneumonia, the symptoms of pneumonia. This is like, you can't take an x-ray of someone's life and pinpoint.
Yeah, it's a lot more complicated.
So what about, you wanted to talk about reliability versus validity in terms of the DSM. What does that mean?
Yeah, so one of the important things when they're revising, and I think it's actually useful to look at this, is, so I mentioned that Huntington's disease, they started describing this 1800s. It took till 1993 before they found that genetic cause.
Wow.
The DSM, the first efforts to actually put this together as a psychiatric community were in the 50s.
Everything before that was each doctor for himself?
It was a lot of people individually throwing out theories. People have heard of Sigmund Freud. There's a lot of different psychiatric theories that have been thrown out, but that was the first concerted effort by the American psychiatric community to say these are the diagnoses. And even then, most people who've seen it progress over time, it wasn't until the third edition before they started operationalizing it to something more close to what we're seeing now.
Okay.
So it's taken a lot of shifts. And over that period of time, there's an ongoing effort to make it better and better and more useful. And so one of the things that comes up is reliability. And that's one of the goals ultimately, is to create a disorder, if we're going to figure out what's going on, that is also inter-rater reliable, which means if I am sitting here as a researcher and we have 5 different researchers, we're going to test how reliable it is if that same patient comes in and presents with the same problem. How likely is it that each 5 of us say it's the same disorder?
Okay.
And how much is that variation from chance? So if we have a very reliable diagnosis,
Reliable criteria, it's written well, you all understand it the same way.
exactly, that means that all 5 of us scientists are going to diagnose that person separately, the exact same way.
Okay.
The less reliable, say only 2 of us diagnose it the same way, that's not such a reliable diagnosis. And so as we've increasingly made these DSM diagnoses and these new additions, we've gotten reliability better, at least in some disorders, where it's pretty good in some of the disorders, but there's still room for improvement. The next stage is validity.
Okay.
So as I was talking about these 5 scientists, I think validity and reliability is actually helpful to think of a dartboard.
Okay.
And so actually back in college we used to have a full wood platform with a dartboard that we could play in our dorm room. And so I'm familiar with hitting, missing the mark entirely. And so when we think of reliability, it doesn't matter where you are on the mark. It matters that everyone throwing that dart hits very close together. So we could be reliable and completely all sticking it in the side of the wall. But we're all sticking it right close together in the side of the wall. So we're very reliable, and then we're all throwing it together. But validity refers to we're actually hitting the mark. And so that's where in the bullseye, we're all hitting the bullseye. So the DSM's aim as it improves is to improve the reliability and validity.
Okay.
We still have work to be done, especially on validity, to make sure that we're actually clear and we're hitting that mark of where we're supposed to be. That's one of the other things that comes up is each edition that we're doing, there's a desire to improve the diagnostic criteria for researchers. And at the same time, there's a desire to improve the criteria for clinicians.
Okay.
And those aren't always aligned. So if you can imagine someone who's doing research, they may have more time to spend with people. So they may be able to take a 3-hour inventory with a person and get very specific. They may be able to get very nuanced between very tiny minutia or details. And there's utility in that because that can be help moving us along and getting a more valid and clear and maybe even closer to that cause of disease. Researchers, they're going to research the DSM as it comes out, and they do research as they're creating new criteria. But say they set the criteria for the DSM. That means that all of the research defining these disorders is going to be based off of that diagnosis. So 2013, the DSM-5 was put out. So that means any of the research after 2013, there may have been some lag time, but basically any research after that, all of the pharmaceutical companies' studies are going to be based off of that diagnosis.
Because the pharmaceutical companies want to treat the specific symptoms as described by the DSM in order to say this medicine works specifically for this
Exactly.
thing.
Exactly.
See.
Which it's no longer now the DSM-4.
Right.
So we're updating, and as we change it, the researchers actually have to follow what ends up being said.
Okay.
And the clinicians have to use what ends up being said.
Okay.
So it's important that it helps further research, but it's also important that it helps further practicality for clinicians because as people who've seen providers can attest to, usually you're not spending more than, I would say definitely not more than an hour and a half, but in most cases it's even, 45-minute initial evals. Okay. And so there's a lot more focused time that they get with a person to make a diagnosis. And so it has to be practical for clinical use as well. Okay, so usually whenever someone comes into the office, when we're trying to understand what's going on, we're looking at what these criteria are. And so the criteria usually involve multiple criteria that have to be met over a period of time.
Always a period of time.
There's always a period of time that involved. Either it has to be present before this age or after this age or for this duration. But there's some degree of time that's relevant to this.
Sure.
That the symptoms have persisted for a period of time.
Okay.
And it also usually will involve, so it's like a number of symptoms.
Okay.
And usually some form of exclusionary criteria, that it's not caused by something else, so that we know we're speaking more about this, not an overlap of a different problem.
Okay.
And I think sometimes when we list a bunch of different disorders, it's important that we have a cutoff limit, so there is an arbitrariness, right? Because any amount of symptoms less than the cutoff is not meeting criteria, but there may be something going on, even for those people who have some of those symptoms, but they're not meeting criteria for the actual diagnosis. And then once someone does reach that cutoff, some of the disorders, like a substance use disorder, they will grade severity based off of how many of the actual criteria they're meeting.
Okay. And are you making these diagnoses off of the individual person and how they are coming in and telling you they're feeling, or are you getting some of this from the people around them? If they come in with their mom and their mom says, well, I'm worried about him, he might not tell you this, but he's behaving in this way. How do you actually pick up on what some of the criteria they might be matching are?
It's a really good question, and part of the reason that it can be so challenging is there's a subjectiveness for every single person in this equation. There's a subjectiveness with which a person presents their symptoms and ability to present their symptoms. There's a subjectiveness in my own interpretation of what they're saying and what I'm seeing. There's a subjectiveness in every family member or collateral that we get. So what I will say is it's useful the more that we're able to kind of peel back some of our own subjectiveness and bias, and sometimes we use rating scales to help with that. But also to hear it from them, to hear it from multiple collateral, the bigger the picture we get, I think it helps provide more clarity on that. Right. That wraps it up for today on the DSM. The next video, we're going to look at some of the specific criteria used to help us diagnose alcohol use disorder. And thanks, this is Dr. Matt Campbell. We'll see you next time. This has been another episode of Conversations with AcroPsych, hosted by Dr. Matt Campbell. Thank you so much for watching. Please leave a comment below for the topics and resources that you want to hear about as our next general educational topic. This video and all information put forth is for general educational purposes. It does not form a doctor-patient relationship. It does not provide any medical advice or individual care. It is in no way a replacement to your medical professional, and we recommend seeking appropriate professional assistance with all your healthcare questions and needs. For any psychiatric or medical emergencies or any safety concerns at all, please utilize appropriate emergency services. This includes 911 or going to the nearest emergency room. For needing to speak to a mental health counselor, there is 24/7 hour hotline that you can reach a crisis counselor.